My topic today is the management of multi-drug resistant TB. Actually, in the field of tuberculosis, we use the term drug-resistant TB instead of MDR TB now because we want to cover more cases of drug resistance like mono-resistant isoniazid. So I wanted to start with this slide, the cascades of TB diagnosis and management. Usually, we use the X-ray to screen the patient and to give diagnosis. And in the programmatic management of tuberculosis, most of the guidelines in the old days we based on the culture DST, culture drug susceptibility testing to diagnose drug-resistant TB. And usually it takes a delay of diagnosis of drug-resistant TB in 2 to 3 months. In some area, in the remote area, the delay went up to 4 to 6 months. So with this, the old concept of diagnosis of drug-resistant TB, especially the MDR TB, there was a delay in the management. Currently, most of the national guidelines in many countries and also the WHO guideline recommend to use a rapid molecular test. Theoretically, you can diagnose MDR TB or drug-resistant TB in 1 or 2 days based on the molecular technique, but in the real world, many events show that still have some delay, 1 to 2 weeks, because the molecular test was not available in the remote area. So they have to send the specimen to the central lab, something like that. And WHO recently published or launched out the consultative guideline for diagnosis of TB. WHO endorsed the molecular test for diagnosis of TB. And WHO recommend to use the expert as a first tool to diagnose TB and also to detect the rifampicin resistance. At the same time, the WHO recommend other tests, but some of the tests need a more complex automated machines and more expensive machine to diagnose a TB and also the drug-resistant TB. But the guidelines say that we can substitute the smear in the way that we use in every country with the molecular test to diagnose TB and also detect the rifampicin resistance. And they say that actually nowadays there are 2 versions of expert, and the company tried to substitute the first version, the MTB RIF, this MTB RIF, with the expert ultra. The difference between these 2 techniques is that the expert ultra, the new version of the expert, they use the IX6110, which is a small copy in the one bacteria, 3 to 25 copies, for detection of the MTB DNA. So it means that the new version, the expert ultra, gives a more sensitivity to detect the TB DNA. It means that more sensitive to detect the TB. But for diagnosis of rifampicin, they still use the RPOB gene as a target to detect, which is means that in the new version of expert ultra, they still keep the same sensitivity of rifampicin detection. And for the MTB RIF, the old version, usually the nickname is of generation 4 of the expert. WHO recommend that we can use it in every conditions, even in the children. But for the expert ultra, the new version of the expert, they recommended in patients who don't have any history of TB treatment before or complete the TB treatment for more than 5 years. The reason is that the new version expert ultra detect the IX6110 small copy. Sometimes we have a false positive. I mean the remnant DNA in the specimen of the patient. So it gives a false positive. Especially in the case that we suspected to have a relapsed tuberculosis. And so they recommend to use it, maybe used, that mentioned here, that may be used But now in Thailand and many countries, we don't have a expert MTB or generation 4 of expert, but we use ultra as a routine. But in Indonesia, several papers published from Indonesia show that even you have a new tools of very sensitive, very fast to get the result, but in the real life, still have a lot of delay here, you see. Even the register send the patient to the central lab and get the result back and start the treatment. We have a delay, not we, Indonesia have a delay of 41 days. So it means that even you have a new tools which is very sensitive, but you have to manage the test near to the patient. I cannot say that this is a point of care test. I would like to say that we should manage this test as a near patient test, not a point of care test sometimes. Technical reason underlying this concept. But one point I will remind all of you in this room that if you want to, in HIV patient, everybody said that HIV positive TB patient usually have a high rate, high prevalence of rifampicin resistant or MDR. But actually I can say that it's higher when you calculate the odds ratio or the hazard ratio is higher than the general population. But if you look at the prevalence of the MDR in the TB HIV patient, it's not very high. I show this slide because I want to remind you that I give the example that in Thailand we have a 4% of MDR in the new diagnosed TB patients. And when you look at this graph, the positive predictive value of 4% prevalence MDR, you get the predictive value, positive predictive value of 60 to 70%. So it means that you have lots of false positive drug resistant. False positive tests. So in the case of TB HIV, I would like to request or ask you to repeat it if you get the result of rifampicin resistant from the first test at the time that you give the diagnosis of a TB in that patient, in TB HIV patient. You cannot rely on the first test because of I think that it based on your prevalence of drug resistant in TB HIV in your country. If it's higher than 10%, you can rely on the first test. So this is a game changer in the tuberculosis. We just got the machine 3 months ago, and we're quite happy with this machine. The MTB XDR, the expert XDR. So it's like a second-line probe assay. But this test uses the same principle as an expert ultra. It's quite easy. I can get the result of quinone resistance just in 2 hours. And I think the sensitivity of the detection of isoniazid fluoroquinone is more or less the same as a live probe assay. Once this, the benefit of the expert XDR is that you can use the leftover sediment from the expert ultra. So if you have enough leftover sediment, you can use it in the expert. So it means that just in 4 hours, if you have the machine, you can know everything about the resistance based on this technique. And it's convenient, and for the sake of the patients, that we can start the treatment very, very early. And you look at the LOD limit of detection, it's 22 cells per mil, which is I think it's better than the live probe assay, which is need a lot of cells, lots of DNA. And in our lab, in my hospital, we have up to 40% of invalid result with the second version of the live probe assay for the second line drugs. So this is a game changer, and I think that if we want to treat the multi-drug resistant tuberculosis patient, we should have this machine for the care of the patients. And recently, I think a few months ago, a systemic review showed that this expert XDR give the same sensitivity as compared to the genotype or live probe assay version 2, which is the one that we use now to detect the fluoroquinone resistance. two techniques in the future that comes to the interest of the many experts or many microbiologists is the MIC study. Very interesting to know the MIC of the strain. So as a clinician like myself, I would like to know the MIC because I can use the data of the pharmacokinetics of the drug to adjust or manage the patient in the difficult to treat the MTB patient or multi-drug resistant TB patients. And several studies, at least two huge studies from published last year, not the result of the study, but the concept or the protocol of the study. Two studies published last year that they tried to correct the data of the MIC of 10,000, 15,000 of M tuberculosis and compare, especially this cryptic consortium, they try to compare the MIC with the genotype. In the same study, they study the whole genome sequence and then compare. So it means that in the future, based on all this data, if we have a large enough data to compare the genotype and the phenotype, so it means that we can use a genotype, this one, the whole genome sequencing, to determine the drug resistance of TB. So it's this one, the technique of whole genome sequencing now is quite, it's more easier, more cheaper than the past. So currently, in our city, we send 100 strains of MDR-TB for whole genome sequencing in the price of nearly less than $100 per test. So with this whole genome sequencing, we can detect all resistance, even the new drug, if you know the genes that related to the resistance, like beta-quilin, pretomanin, chlorphazimine. Comes to the treatment of, so that's the part of a drug resistant diagnosis. And comes to the definition of the treatment of MDR-TB. 2 years ago, with the new classification of a second-line drug, WHO gave the new definition of a drug resistant, like especially the pre-XCR, the XCR. I will show the study that why WHO changed the recommendation. The new definition of pre-XCR is MDR-TB which resists to fluoroquinolones, not the ammonium glycoside. And also the extensive, the XCR definition changed to MDR-TB which resists to fluoroquinolone and one of the two drugs, plus one of the two drugs of beta-quilin and linezolid. This is the new definition that used, and I think it's recommended by the WHO group, expert WHO group. And this is a development of the classification of second-line drugs. Before 2016, they used a 6 class of the second-line drug. 2016 to 2018, they changed to group A, B, C, D, D1, D2, D3. But now, 2019, and the full consolidated guideline launched out in 2020, they changed all the drugs in the second-line groups to 3 groups of drugs. The first group is a group A, levofloxacin or quinolone, beta-quilin, linezolid. The group B is chlorphazimine, cycloserine, and terlicidone. And group C, ethambutol. And I put the red arrow here because the WHO recommend that you have to select the drugs from the top to the bottom. I mean that you use a drug from the first, and you can use any drug, use substitute with the next drug for, from up to down. And this is based on this classification in before 2018. Most of the guidelines use clindamycin, amikacin, levofloxacin, etomidate, cycloserine, plus or minus pyrazinamide and PS as a recommended regimen for the MDR-TB. But after these classifications, the milestone study that published in 2010 in American Journal of Respiratory Medicine, 2010, from Professor Van Doon in the Diamond group. They study in Bangladesh, so the nickname of this regimen is Bangladesh regimen. And they try to substitute one drug with another drug and see the result of the study. They conduct this study of 6 to 8 years, I think so. And came out with the regimen with this 9 months of 82.5% success rate and failure of 0.5 and relapse of 0.5. Just in 8 months or 9 months. So this is the beginning of the era of the shorter regimen for the MDR-TB treatment. And this regimen, 8 months with the 7 drugs for 4 months and 4 drugs for 5 months, had the less side effects and higher success rate. So again, I will move to next slide. So this is a regimen recommended at that time: kanamycin for 4 months, and levofloxacin, chlorpheniramine, ethambutol, paracetamide for 9 to 11 months, and in the first 2 months, add the protonamide and high-dose isoniazid to the regimen. This is a short course regimen for MDR-TB. Can we use this in HIV patient or not? Yes. Yes. Sorry. And in 2018, 2 studies using the individual patient database, isoniazid resistant, I think it's about 9,000 cases, and MDR in our 12,000 cases. They correct the data in the patient and analyze. And the group of this, a group who did this was a group from McGill University, Professor Dick Manzi, published in 2018 in Lancet Respiratory Medicine and Lancet, especially in this multi-drug resistance. They study and all the data, they came out with the data that any patient who received the kanamycin has a lower success rate and higher mortality rate. So WHO cut the kanamycin from the list of the anti-TB drug. Only the amikacin that has a little bit high success rate and lower mortality rate. So in the field of tuberculosis, we use amikacin as a first aminoglycoside for treating the TB patient. And with that studies, WHO changed the recommendation from kanamycin to amikacin. So this is shorter. We use it for several years. And again, the data from South Africa, because bedaquiline registered to US FDA in 12 December 2012, and in 2013, bedaquiline was available in South Africa, and they use our bedaquiline for the drug-resistant TB who cannot tolerate the aminoglycoside. So in 2018, they South Africa group gathered all the data in the use of this bedaquiline and showed that in the MDR-TB patients, when you change the aminoglycoside to bedaquiline, you reduce the mortality rate significantly. You see, for the total whole group, reduce nearly, I think, 15%. For XDR, 25%, and for the MDR, 50%. So with this data, the show again, and in this group you can see that most 63% of them had co-infected with the HIV. With this data, the WHO changed the recommendation, substitute the amikacin with the bedaquiline. Yeah. So this is the last regimen, the regimen that we recommend to use now before we change to the new shorter regimen. Based on the study, next study published in 2020, a group, Professor Kondali from South Africa, published data that because at that time they don't have a choice to treat the XDR-TB patient in South Africa. Two new drugs, protonamide and bedaquiline, available in South Africa. Like this is available in the market for a long time for the MRSA treatment. So they try to treat the XDR patient or any MDR-TB patient who cannot tolerate the shorter regimen with this new regimen, the B-PAL regimen, bedaquiline, protonamide, and linezolid. Very good. Even the number of the cases in each arm was very high. Was not very high. That's 100 cases. they can get the success rate of favorable outcome rate, or in the old term you use the success, but now in the field of tuberculosis we use unfavorable or favorable outcome. So it's a composite outcome to determine the side effects, also the dropout, the death in the patient. And they can get the unfavorable outcome of 90% in the XNRT patient. Very interesting. As everybody, how can they do that? With just only 3 drugs, success is 90% in 6 months. Very good. Excellent. But the point in this next TB was the high side effects of linezolid. 30% of the patient has to drop out from the treatment after, they are allowed to drop out the linezolid after 4 months of treatment. So the point is that in this next study, they use a high dose of linezolid, 1,200 milligrams per day. That's the dose that we use in the MRSA or other bacterial infection. The next studies, shall I go back? Cynic studies published, I think it's early last year in New England Journal. They compare, they want to determine the dose of the linezolid, 1,200 milligrams or 600 milligrams. Most of the TB experts like myself, I use the 600 milligrams for the beginning, but they want to test the concept that 1,200 or 600 once daily or twice daily. See, the result came out with that 1,200 milligrams per day and 600 milligrams gave the same result of success rate, but 1,200 milligrams per day had a higher side effects, much higher side effects from linezolid. So from Cynic study published earlier, the learning point in the study is that 600 milligrams of linezolid in the MDR-TB patient is enough. Once daily is enough. And another point of the Cynic study is that the dosage of beta-carotene, they use a new dosage of beta-carotene. Beta-carotene, you use the recommended dose from the company, Johnson company, is at 400 milligrams per day for 2 weeks, and 200 milligrams 3 times a week for another 24 weeks. So that's an inconvenient for the patient and also for the doctors. I have an experience with my young staff that they forgot how they still believe that beta-carotene can give daily in a daily dose. So the Cynic studies they prove the concept that the beta-carotene new dosage is 200 milligrams per day for 2 months and 100 milligrams per day for another 24 months. So that's a 2 learning point from the Cynic study. This is just published 3 weeks ago in New England Journal, the TB practical study. So this is a basic data that the WHO used to change the recommendation for the MDR-TB treatment now. And I think that most of the countries in the world will follow the WHO recommendation. Okay. They compare the B-PAL plus moxifloxacin and B-PAL plus chlorpheniramine and B-PAL as a control, and compare to the standard of care like shorter regimen, beta-carotene shorter regimen 9 months. And from the phase 1 study, they found that the B-PAL moxi and had the higher conversion rate at 8 weeks compared to the B-PAL. B-PAL is good, but B-PAL moxi, B-PAL-M much better in terms of eradication of the bacteria. So it means that you reduce the possibility to have a failure and also the relapse. And again, you can get the very high success rate with the B-PAL-M. And another study was change the progesterone in the oral shorter regimen to the linezolid. So 1 month ago, 15th of December 2020, WHO launched out the recommendation, because the guideline that now they recommend to use a B-PAL-M as a first line for the treatment of MDR-TB. And if you cannot use the moxifloxacin, you can use a B-PAL. And in the oral shorter regimen, substitute the progesterone or etimide with the linezolid 2 months This is the newest recommendation from WHO. And it's very convenient. We use a BPRM in our institute for nearly 20 cases. Very, how can I say that? Very much less side effects from the drugs as compared to the shorter regimen and more acceptable for the patient. Can you use in the HIV patient? Yes. Any case with the MDR, you can use the BPRM or BPAL. So, except the exam pulmonary TB with miliary TB and TB meaning or TB osteoarthritis. So, this is summary. So, in summary, molecular test is a standard test for diagnosis of drug-resistant TB. Not only MDR, but except the paracetamide. But for the isoniazid also, we can use expert XCR or the rapid to detect the isoniazid monoresistant. Now, the treatment of MDR changed from the longer regimen, very toxic, less effective, to the new 6-month, 4 drugs or 3 drugs with a higher success rate. And also, all these treatments can be used in or recommended to use in the HIV TB patient also. Thank you very much. I would like to end my talk here.